Okay. Okay, so welcome everybody. Thank you for joining us. A couple of announcements before we get into tonight's speakers. We will be sending out a little poll to everybody, but we are kind of looking to switch up these monthly meetings a little bit. Some months we will still have speakers, just like we have been doing for as long as I can remember. So we're not going away with this, but we want to enhance like the community and enhance these meetings. So we want to get input from you guys, but what we were kind of thinking was like 1 month have a speaker, the next month have more of like a social, we're not sure we want to call it peer support, but just kind of a more social meeting where like we just kind of talk and share how we live and maybe bounce ideas off of one another, things like that. And then have another meeting where, I don't know, we had a couple of different topics and I didn't write those down to have in front of me. But we do want to know what you guys want, what, you know, if you like this format, we have a speaker and then that's it, and we don't mess with it, then we won't mess with it. But the board was just kind of talking, and we, you know, want to like spruce some things up and have more of like a social community with this chapter and with all of our members, and kind of build up from there. So something to be on the lookout for. I will try to have that come out in the email tomorrow with the replay of this. So please submit your responses. It'll be anonymous. We won't know who's saying what. But I mean, we are here to serve you all. So we want your input. What would you like to see in the future, next year, things like that. So that'll be coming. Another announcement, which had come out in the email as well, is that the Ohio Pain Clinic is doing a research. And if you live in a 4-hour drive of Dayton, Ohio, and struggle with constipation and you have a spinal cord injury, they are recruiting for that. The study would be a half a day in Dayton, and I will put in the chat the phone number and email to inquire about more specifics from that. I kind of don't know much about this research study. My supervisor was looking into it a little bit more. So if you want to get a hold of them and find out more for yourself, their contact information is in the chat. Something that Metro Health is putting on their STAR group, its Support Trauma and Recovery group, is hosting a virtual Reiki relaxation and pain management group session. It's via WebEx on November 3rd, and that is from 1 to 2 p.m. In the afternoon. And if you are interested, then you'll want to get a hold of Cheryl Crahan at Metro Health, which is now also in the chat, and was also in the email. Gosh, lots of announcements tonight. The last round of $50 grocery card gift cards will be this month. We have just shy of 30 left, I believe. So I will put that link in the chat as well. But if you have gotten one in the past, you are welcome to fill out another Google form for another one. We will be cutting it off at some point, and whoever has not gotten a gift card yet will get that first, and then we'll kind of go through the list based on how many you have received. But by all means, put if you want one, need one, fill out the Google form. That link is also in the chat. And then we do have KN95 masks. So if anybody needs one, send us an email. We will mail you out a couple. We have a ton of those to pass out. Okay. We are starting to plan next year's speakers. At this point, we will continue with the virtual meetings just until something else changes. So if you have any topics, any speakers, any suggestions, ideas, let us know. Again, we are here to serve you guys, and we don't know what to offer until you guys tell us. So let us know who or what you would like to hear about next year. So with that, I will introduce our first speaker. We have Richie Nagy joining us today. He is the son of Laszlo Nagy, if you guys know Laszlo. But Richie owns a business called Nepos Senior Services, and I'm sure he's going to tell us all about it, but it's hooking those in need up with different surfaces. So Richie, thank you for joining us, and take it away.
Well, Megan and Dr. Nemunaitis and everyone, thank you for having me. Just want to say, go Flyers, go Dayton. I'm gonna see if I can share my screen because I have a little PowerPoint. Oh, okay, Megan.
Just a second and you will be able to.
I've never shared my screen before, so if something happens, forgive me.
You should be able, oh wait, who can? Yes, you should be able to now.
All right, can everyone see?
Yep.
Perfect.
Yep.
Okay, so my company is called Nepos Senior Services, and I am the founder and CEO. And our logo is linking lives because that's what they're business of. Now, you're probably wondering, what does Nepos mean? So it's Latin for grandchild or descendant. And I originally started it as an idea in August of 2019 when my grandmother moved in with us. It's been over a year now. And we realized she doesn't necessarily need medical help. She just needs, help around the house with odds and ends, maybe going to the grocery store or help with something just in the kitchen or something. So that's where this came about. And then in February, I officially launched with the federal government in the state of Ohio. I filed and I was officially incorporated as Nepos Holdings LLC. That's just the umbrella. So if I wanted to branch out, I can branch out. So I'm doing business as Nepos Senior Services. And I've just been researching what are the needs of older adults or just people in general who need unskilled non-medical care. And I found in the Cleveland region, it's everywhere. There's older adults, and then there's just people in general who just need a grandkid, who just need someone there to help them with grocery shopping or navigating the computer or their new smartphone. Pictured below is me and my grandmother, who I'm talking about. So these are our mission and goals. We want to provide excellent care for older adults and others who need assistance, like I said, with non-medical and unskilled care. We also want to offer gainful employment to young adults, especially college students, pursuing careers that directly work with older adults. And as I have below, we're targeting college students who are studying pre-medicine or pre-physical and occupational therapy, psychology, social work, nursing, and more. I mean, and the and more can be, you know, personal finance, because everyone needs to know finance, keep their checks in their bank in line. To qualify, you have to at least have a 3.0 cumulative GPA. And as a thank you for working for our company, after 50 visits, we will provide as a company a reference or letter of recommendation saying, listen, they were able to complete 50 visits, maintain their 3.0 GPA, along with everything else that they have in their life. They're responsible, they're prompt, and our clients have said XYZ things about them.
Hey, Brand, talk.
Everybody,
What?
mute, please.
You want him to say?
The website?
Wait, wait, we have muted.
And so one thing that I pride myself on is that, you know, I'm very flexible with what I can do. I can do everything from technology navigation to yard work. This past summer, I seal coated someone's blacktop driveway. And it's all I can, and for payment, I can take cash, check, credit card, and it's on demand, just like an Uber. Think of Uber or Lyft. I'm here, and if you need something, you just give me a call or an email and we set it up and I'm there. Or your Nepos caregiver is there. So I have a few, you know, Q&A. How much do I charge? I charge $23 per hour. That's the going rate for this type of service in the Cleveland, Ohio area. And like I said, my model, it's just like an Uber or a Lyft, but instead of doing car share, it's caregiving. I'm here pretty much 24/7. I just need like a day's notice or even an hour's notice, and I'm where you need me to be, whether it be taking you to the grocery store, to the bank, to the doctors, or helping you do contact-free shopping and delivery because of COVID to help maintain that physical distancing. And as a result of COVID, I'm offering, you know, contact-free virtual visits to help alleviate that social isolation of not being necessarily around a lot of people, but just to provide that service. I also do, I mean, pretty much everything that you need me to do. As long as it's non-medical or unskilled, I'm here for you. My contact information is here. As Megan says, she's recording this. I can also send her this presentation and she can send it out to all of you. I can be contacted via telephone at 216-645-2590. Or you can check on my website and contact me that way. It's also a direct link to my email. And my email is richie@neposservices.com. So now I'm opening the floor up to anyone who has any questions.
And I did put all of his contact information in the chat. Any questions?
Hi, I think this is a great idea. Would you meet with the people before they work for you? Like a background check? Okay.
Yes. So like, you mean if you hired me, you want me to do give you like a background check? Or if I like hire someone and then they come to you? Yes. For all employees, they will receive a full background check. They have to have a valid driver's license and a valid .edu email address to prove that they are enrolled in an accredited institution of higher education.
That's great. I'm in an OT program at Cleveland State University, and this would be something really cool to do as an undergrad.
And that's the interest here, because I'm looking to hire people like you who are studying occupational therapy or physical therapy to help just anyone who really needs help, whether it be an older adult or someone with a spinal cord injury or someone who maybe has MS or some other physical limitation, I'm just there to help.
Any other questions? Okay, well, thank you, Richie, for joining us. If anybody needs help around the house or anything like that, reach out, let them know. Any college students that want to work for him, let them know. Thank you.
You're very welcome.
So now we are going to hear from our second speaker. You may know him, Dr. Nemunaitis. Thank you for joining us. He's going to talk to us about autonomic dysreflexia. And if you could all mute yourselves just so we don't have any interference, that would be great. Where's my mouse? Here we go. You're muted, Greg.
Can you guys hear me now?
Now we can, yes.
And I don't care if you mute yourself or not. If you have to interrupt me, please interrupt me when I'm presenting. All right, so we're going to talk about autonomic dysreflexia. And I actually put this talk together for the Middlefield Fire Department and Geauga Community Hospital because they had an issue with AD out there in Geauga County, and I responded by putting this together and giving them a presentation. And this is just some of the things I do right now. And we're going to focus on defining AD, understand the pathophysiology, recognize signs and symptoms, and how to treat. And this is a real live case. And in fact, this guy called me 10 minutes ago and said he shot his first deer since his injury with a bow and arrow. So I was pretty proud of him. He was 50. He presented to the ED in 2015 with a C5 vertebral fracture. He was taken to the OR and fixed. His hospital course was complicated by respiratory failure, requiring ventilation and tracheostomy, dysphagia requiring peg tube placement, pneumonia, pressure ulcer, and blood clot. He was transferred to an inpatient SCI rehab facility and discharged to home with C5, Asia B, tetraplegia, with restrictive airway syndrome, neurogenic bowel, and neurogenic bladder. In 2018, he was at home, and this information came from him and his wife. He developed a headache and a large blood pressure. He also had a distended abdomen, chills. He had severe muscle spasticity, and so bad that he had difficulty breathing. His wife called EMS. They picked him up, and en route, he had an intense abdominal spasm, and he desaturated. His oxygen level dropped. He lost consciousness. His wife said he turned gray, and she thought he was going to die. EMS applied oxygen, got to the ED where systolic pressure was now 230 millimeters of mercury. He was conscious and complained of bloating, nausea, shortness of breath, and continued to require oxygen. His white count was 13. couple days later, the wife was frustrated and called me because nothing changed. He still was hypertensive, still couldn't breathe. And after reviewing everything, I told her to do some ditch stim and insert a suppository. And I also called the attending because I felt it was not right to manage a patient over the phone at a hospital I'm not a member of. And I said, he needs a bowel movement. And he just laughed. And I said, okay. But he ordered a CT of his abdomen. But while he was just after the CT, his wife went into the room, did some ditch stim, and placed a suppository in a huge BM. His blood pressure returned to normal. He no longer needed oxygen, and he was discharged to home the next day. So what did he have? He had autonomic dysreflexia. It's an acute syndrome of sudden onset, characterized by elevated blood pressure, headache, and in some cases, bradycardia. And it's more significant at T6 and above level. AD is defined by blood pressure elevation of more than 20 millimeters of mercury above baseline. AD may or may not produce symptoms. AD can happen anytime after spinal cord injury. And AD is potentially life-threatening, and a delayed diagnosis or treatment can result in stroke, seizure, hemorrhagic infarct, pulmonary edema, stroke, and death. This is just a paper by Juan in 2014 where he reviewed 32 cases of people that had AD associated with life-threatening outcomes and or death. In this group of 32, 72% had a CNS complication, brain hemorrhage, seizure, or infarct. 22% had cardiovascular complications. 6% had pulmonary complications, and 22% died. So one of the things to keep in mind is that AD is not always hemorrhage of the brain. AD and elevated blood pressure could blow a vessel anywhere from the brain to the heart, to the kidney, to the lung. This is an article by Lee in 2017. He looked at the prevalence of AD in a group of 28 individuals with T6 and above level of injury. 24 were tetraplegic, 24 were incomplete, mean age 56. Mean duration since injury was 28 months. In his methods, AD was defined as systolic blood pressure 20 millimeters of mercury, higher than basal systolic. Blood pressure was recorded every 30 minutes for 24 hours, and these patients were given a questionnaire about autonomic dysreflexia. AD was demonstrated in 26 out of 28 individuals, or 92%. Mean AD frequency was 5 times in 24 hours. 16 of the patients were symptomatic, while 12 were asymptomatic. So you don't always have symptoms when you have AD. And how is AD generated? It's a reflex response. AD is caused by nociceptive input or painful input. Like you stick yourself with a needle where you can feel, that's pain. So that's nociceptive input. Can trigger a sympathetic surge. And the most common one really is bladder distension, blocked Foley, UTI, debris, which will trigger nociceptive input to the spinal cord, reflex vasoconstriction, which narrows the blood vessels and causes the blood pressure to go up. This blood pressure will be sensed by receptors in the aortic arch and the carotid sinuses, and will tell the vasomotor center to slow the heart rate down to try to improve the blood pressure. Well, this parasympathetic ultimately increases not only bradycardia, but causes flushing and sweating above the level of injury. So just some other signs, but again, it's only present in 50% of people. One of the things people say is T6 is the most significant level and above for autonomic dysreflexia. And people say, well, why is T6 the magic number? Well, in fact, you can get AD at almost any level of spinal cord injury, as long as the injury is above the conus. But the important feature is the splanchnic vasculature, or the blood vessels that go to the colon and all the organs. That comes out between T5 and 12. So if your injury is above T6, you virtually have all your splanchnic vasculature under autonomic control. And so if you get that sympathetic surge and vasoconstriction, your blood pressure is really going to go up. So that's why that T6 level is so important. These are some causes of spinal of AD. And the common, uh-oh, I hear an alarm. Somebody needs to take their medications.
Ha ha ha.
Oh no, my wife's got that too. So that's why I automatically said it. So bladder, number 1, 2, and 3 causes of AD. And it's usually a distended bladder or a blocked Foley. Bowel constipation, hemorrhoids is a problem. Just gaseous distension can trigger AD. Skin, pressure ulcer, ingrown toenail, burns, tight clothing, fracture, tendon injury. Somebody was kicked by a horse and asked me to put that up there. So a bruise, and anything else. A sunburn, poison ivy, aerophagia, which is swallowing air, appendicitis, labor, intercourse, iatrogenic, clamping or kinking the Foley and not releasing it, lying on a bedpan, failure to weight shift, tight shoes, shoelaces, or even just getting your blood pressure checked repeatedly can also cause elevation in blood pressure. Signs and symptoms: pounding headache, anxiety, flushing above, blurred vision, dry, pale skin below, nasal congestion. Signs, number 1, hypertension. And in about 50% of the people, reflex bradycardia, sweating above. You can get arrhythmias, piloerection or goose pimples, and increased muscle spasticity. Treatment: let gravity help you. So sit the person up. Loosen clothing, monitor blood pressure. Systolic pressure above 150, you want to put nitro paste on. But the number 1 thing to check is your bladder. If you have a Foley, flush it or remove it and replace it, because this reflex is over as fast as it starts, because once you drain that bladder, blood pressure will immediately come down. Check the bowels for stools. Sometimes you need lidocaine gel to prevent noxious stimulation when you put your finger in. And then some other things you can check. Anybody that goes to an outside hospital other than Metro, I think Metro's got it down in the ED, but no matter where you go, you really need some backup. And I would get this card from Christopher Reese Foundation, or the card, the chapter. We had some, I don't know if we still, but pass them out so that you have another source of reference whenever you go to an ER, because not a lot of people know about this, unfortunately. But it's a good backup. So back to the case. Autonomic dysreflexia may also be caused by accumulation of triggers. So one thing may not have triggered AD, but a lot of little things could have triggered it. So let's look over this case. And when we looked at this guy's abdomen, we see some stool in the transverse and descending colon. We see some bowel gas, and we see a lot of air in his stomach. This is what that aerophagia is, a swallowing of air. So these three things are triggers. In the CAT scan, we also saw some esophageal thickening. So he likely had some esophagitis, providing some input to trigger the AD. A lot of times we look for stones and blockages of the renal pelvis and the ureter. And I only put it up here for completeness because he didn't have it, but that's something we look at. He also had a distended bladder. One of the things he does at home is straight cats every 6 hours. Well, when he went to the ED, you know, they're thinking this guy can pee, and obviously not. So that was another trigger. And then the last trigger is, in his case, was he had some HO on his left hip. So whenever he was leaning on the left side, it would trigger more nociceptive input to the spinal cord and more rise in his blood pressure. So he had multiple things that added up to cause this significant autonomic dysreflexia. These are just some other triggers I thought was cool. These are gallbladder stones, ileus. This is a big bladder stone, ulcer, esophageal ulcer, pressure injury, just a small little sore or a big sore, or ingrown toenail I've seen as a significant trigger. As you recall, he had a lot of problem breathing. And why was this patient short of breath? And this little drawing is something that I put together just to explain why he was short of breath. But to tell you, explain it, I need you to understand normal. So this is his mouth, his airway, his trachea to the left and the right lung. This is his diaphragm. This is his abdomen. And this is the space, airspace around his lungs. When we normally breathe, the diaphragm descends, making the pressure negative inside here. And if pressure is negative inside there, then it causes the airflow into the alveolar spaces to take up that negative pressure. If you cannot contract your diaphragm because you're full of stool, gas, and air, you're not going to ventilate. Furthermore, you're going to have problems getting rid of secretions. You're going to tend to have junk pool in your lungs. So this is actually his part of his lung x-ray. You can see he had developed atelectasis here. His constant work of breathing with a low oxygen saturation is going to cause that muscle to fatigue. High pressure could have added pulmonary edema. We already know he's got aerophagia, meaning he swallowed air and he couldn't contract his diaphragm against a large distended abdomen. And finally, most of us know that AD is not always a bad thing. It can be emergency, but it can tell us that something's going on, and as long as we're capable of having somebody close by to figure it out, it can limit bad consequences. And everybody should also have some nitro paste at home if they can't figure it out, and a place to go and bring your AD card. All right, thank you. Open up your phone lines. I hate talking into a vacuum, and ask questions.
I have a question. Nitro paste, does it really expire after a year?
Megan, you're talking to the wrong guy. I still use medications that's 30 years old,
Okay.
but yeah, I would. The proper answer is yeah, I would replace your nitro paste because you know it works. If it doesn't work for whatever reason from degrading over time, then you're in a bad way.
Where do you get nitro paste?
Your family doctor.
That's a prescription then?
Yes, sir.
Okay, thank you.
Or your rehab doctor.
I have a question. My name is Tiara. This is my first meeting, but
Welcome, Tiara.
Thank you. I have, sorry, I'll turn my video on so you can see me.
Oh, you're lovely, Tiara. Thank you.
Thank you. I always have this issue, right? Well, not as much with my normal physicians, right? Like my urology team or my physical therapist or my neurology team. But when I see other doctors or if I have an emergency room issue and I'm trying to educate the medical folk about my body and the things that I know that could be the issue, I instantly feel this agitation that I don't know what I'm talking about. And it's like how that couple, until they called you or you called the attendee, it was like the most obvious thing they didn't test for. So I'm just curious if you have any advice about how I can, or any of us can, be an advocate for ourselves without offending, which you shouldn't do, but I mean, I don't know how you can do that, but without offending the medical personnel. Like, how do you educate them about your body? Because what might work for another patient, because doesn't work for you because you've been living with this injury and the effects of that for a number of years. So I'm just curious to hear your thoughts or advice about it.
Your feelings are so common, I can't tell you. Furthermore, I'm an attending physician, and I'm gonna underline right here. Well, when I called him, he laughed at me on the phone. Mm-hmm. I mean, how degrading is that? I'm trying to help him save his patient, and he thought I was a crackpot. So I truly understand the way you feel, and that's why I say have that AD card with you. Have a reference material for those guys. No offense, but some of the docs have the biggest egos you ever want to deal with. But different people in different places have big egos too. But give them some reference material. Bring that card with you at least. And tell them to look it up, and and that's all I can say. You may want to try to educate that system of care. You may want to get your family doctor or rehab doc, somebody knows about AD, to give them a little talk. If you want this lecture, I can send it to you. Or I'll send it to Megan, and Megan can send it to all you guys. Whatever you want, you could whatever you want with it. But it's a big problem, and that's why I'm talking about it, because I was frustrated too. But I knew I knew as soon as he pooped, it was going to be fine. But anyhow, thank you for the question.
If anybody on the call, if anybody has a printer, I did put 3 different AD cards, links to them in the chat. And then maybe this is something the chapter can work on as well to provide. Or just if you get it on your, if you have a smartphone, you can get it up on your phone and take screenshots of it. If you don't have a printer, there's another option. If you have access to all of that stuff.
And if they call the Christopher Reeve Foundation, they'll send you one.
Yes. Anybody have any questions?
Doctor, this is Mark Hyder. I don't have any questions, but I did send over on your phone a couple pictures of Joe shooting his crossbow.
Oh, awesome. That's awesome.
But
Tell
thank you
Mark
for
Hay.
Yep, thank you for the presentation.
Yeah. This is the medical alert card we did years ago. And we had them laminated and passed them out. It actually opens up. It says autonomic dysreflexia on the back of it. And then it explains things on the inside. It's got all the different stuff on it. It opens up. It's got it all on the inside. We just had a bunch of these printed and laminated years ago and passed them out to everybody.
Hey, Dr. Nemunaitis, I got a question. How long was this guy constipated? How long since he had a bowel movement was he backed up?
Oh, this guy, probably 3 days.
3 days? And that could happen?
It wasn't that long, but he had a combination of he swallowed air into his stomach because he had sleep apnea. And when he uses the BiPAP machine, that BiPAP machine actually helps force air in the stomach. He had gas and he had stool.
Hello, doctor.
Yes, ma'am.
I have a T4 to T6 syrinx, so syringomyelia. And I've been suffering with autonomic dysreflexia since my first operation in 2003. And it was a real question. Nobody knew what was going on with me. I would have these occasional bouts that would seemingly come out of nowhere, although it did seem like it was relative to a combination of factors. It's interesting to hear you say that. Combination of factors that included a full bowel, a full stomach after eating dinner, usually always after eating dinner. And I didn't know what else. Could have been the excitement of the day. I wasn't sure what was going on. So an accumulation of stressors or factors seemed to be my conclusion after many years of trying to figure this thing out. And it's encouraging to hear that you had the same that same multi-trigger syndrome that causes it.
Right.
Mine, unfortunately, seemed to last for 4 hours. I'd go into, after dinner, I would get flush, didn't know what was going on. I would have dumping syndrome. I don't know if you probably know that, where literally I would empty out. I'm still ambulating and able to have some control over my bowels. But I hope it's not grossing everybody out to say this, but I literally would empty out my entire large intestine, which is kind of odd, to go 9 times. And then that would increase my tone. I would have gait issues after that, increased tone. And then my heart rate would just go screaming along. And then I would have extreme nausea. And I would take medication to calm down my heart rate and also to calm down my body in general. I could almost feel the swings from the sympathetic to the parasympathetic, strangely. Has anybody else had that experience? These episodes would last 4 hours. Is that unusual?
I've never had it.
And not everybody will get it. Not only the level of injury is important, the incompleteness of the injury is important, and whether your spinal cord was infarcted.
Infarcted, you mean
dead. Dead tissue is infarcted tissue. So usually with a spinal cord injury, you just have a small area of injury, like an inch, and your cord below that is alive. And that's where the reflexes are the automatic reflexes are that are a problem. But if your cord is infarcted, all the cells die. And so you wouldn't have that reflex pattern. You wouldn't have any spasticity either.
So that I am getting spasticity means that there is no infarct.
No, you don't. If you have AD and spasticity, you don't have an infarcted cord, no.
Okay. When you're talking about the autonomic system and the area T4, 5, 6, is the autonomic nervous system centralized in that area particularly?
No. Your autonomic nervous system reflexes span the cord from T1 to L2. And you'll have, just like a knee reflex, a sympathetic reflex at each level. At T6, you've added the splanchnic circulation to your reflex autonomic dysfunction, so you're at a higher risk for getting significant blood pressure changes.
So 20 points, is that it? Is that the, ordinarily I have low blood pressure? Well, 110, whatever. And it'll go up to 130 over or whatever. I can't remember.
Okay, so you need to start looking if your blood pressure goes up 20 points. Absolutely.
In that 20 point increase, if you can't bring it down, it seems like the propranolol brings down the heart rate, which also seems to bring down the blood pressure.
Yeah, that used to be the medication of choice back when I was in school or in training back in the 80s. And you can still use it, but the problem with propranolol, it's systemic. So once it's in your body, you got to wait till the action goes away before you can set up. Whereas nitro paste, it brings the blood pressure down. Once you figure it out, you wipe it off, and it no longer exerts its effect on the body. But
nobody has ever told me about nitro paste.
Pardon me?
Nobody has ever told me about nitro paste.
Yeah, well, now you know, and you can go to the Christopher Reeve website or American Spinal Injury Association, look at their handouts or.
And it's something you apply where?
Generally, we put it on the chest, but anywhere that you have good circulation.
And the, does it bring down the heart rate and the blood pressure immediately?
Yep. Within seconds.
Really?
Yeah.
Does it stay in your system? You say it doesn't stay in your system as long?
If you wipe it off, it's no longer active.
Really?
Yep.
Well, this is a I'm so glad I joined. I really appreciate knowing this. Could be a game changer for me.
It saves lives, quite honestly.
What is the difference between the paste and taking the nitro, those tablets that you dissolve under your tongue?
Well,
they're talking about two different things.
Well, they're pretty much the same thing, but if they dissolve under your tongue, they're in your system, and your liver's got to metabolize it for the effect to go away.
Okay.
But, you know, you have more control if you have the paste. But when you wipe it off, make sure you wipe it off with a glove or a napkin. Don't put it on your hand, because then it'll also cause you to drop your pressure. I did that once.
Yeah, this is what it looks like if you can see.
Nitrobid.
Is that the right one, doctor?
Yes.
Okay.
Can you take that proactively if you know you're going to be in a situation?
I used to have I wouldn't take it proactively, no, because you don't know for sure. But I would have it handy. I was gonna tell you a story about a friend of mine, John, who was a high-level tetraplegia. Back in the day when we were using Procardia, when he was having sex, he would put the Procardia in his mouth, and just before he ejaculated, he'd bite down because he knew he would have bad AD. So yeah, people have done that, but I would be cautious because you don't know. You don't want your blood pressure to come down from baseline. If your systolic pressure is 90 baseline, you bring it down to 60, you might infarct your brain, your kidneys, or your heart. So it's not a toy. It's something useful when your pressure's higher.
Is there is there a danger of it coming down? What is the lowest? I mean, how low does it go before it gets dangerous?
Well, you got to keep taking your blood pressure.
I mean, is the top number at 90 low and dangerously low, or?
No, it depends what your starting number is.
Well, say I'm 110 over my average.
So, you know, if your blood pressure drops to 90, are you going to start feeling dizzy?
I don't know. I mean, I'm usually lying down when these occur because I'm pretty sick.
If your blood pressure goes 20 below normal, I would wipe it off. You don't need it anymore at that point. I mean, you're only concerned about blood pressures above 150 systolic. The diagnosis is made at 20 above resting, but you really don't want to use the nitro-paste until it gets above 150.
Down over there.
And that's consistent with what's written with the Christopher Reeve Foundation.
And if you wanted to listen to whatever you're listening to there, that's...
And Megan, you're going to have to send me your Gmail account because this lecture is too big for inter-office mail.
Okay.
Thanks.
Dr. Nemunaitis, I do have one more question. I'm sorry if it's late.
Who's that?
It's me, the medical student, Bosch.
Bosch, what's up?
So clinically, how can we distinguish autonomic dysreflexia versus autonomic dysfunctions, and does the treatment differ?
Autonomic dysfunction is different in that it's a consequence of your spinal cord injury. It's not necessarily going to cause a problem. Autonomic dysreflexia is an acute emergent episode related to elevation in blood pressure that can predispose to cerebral infarction, cardiac infarction, pulmonary edema, etc. But yeah, they all have autonomic function. And, you know, the orthostatic hypotension is a great example. You know, when you sit up, you don't adjust your blood pressure. So your blood pressure actually tends to drop when you sit up. You know, if your level of injury is above T1, you will not have any sympathetic response to central drive because your sympathetic is disconnected.
Okay, thank you very much.
All right, you guys, it was nice talking to you.
Yes, thank you.
Thank you very much.
Thanks, doctor.
All right, we'll see you guys later.
Thank you, sir.
Bye-bye.
Nice
Bye-bye.
job. Thanks.
Thank you.
Thank you.
Thank you all for coming. I will send out a video replay email with the chapter meeting poll survey, Richie's presentation, Dr. Nemunaitis' presentation, the links to the Autonomic Dysreflexia cards, and the grocery card gift card Google form. I hope I'm not missing anything.
Thank you very much.
Absolutely. So thank you all for coming. I hope you found some value out of this. It's never.
Now, I just have a question. I'm sorry.
Sure.
You see my name up here, Jessica Kircher?
Yes.
Do you have my email?
I don't know.
I'm not sure if I really very much would like to have all the information, and I'm not sure about screen share and all of that. I'm really technologically handicapped. So,
Yeah.
Could I just give you my email, or how do you, is it evident like a cell phone call? You can see it?
I only see your name.
How would I get that to you?
If you, I will, if you could email me, that would be
your
great.
email?
My email is Hammond, HAMMOND .MEGL @gmail.com.
Nice. Ariel.
HAMMOND.NEGL@gmail.com.
It's MEGL, like Meg L.
Oh, I'm so glad you corrected me. M as in Meg.
Yes. Hammond.megl@gmail.com. Email me and then I can add you to our email list.
I'll reference this meeting as the just AD meeting.
That would be great. Yep.
Thank you very much.
Absolutely. So yeah, if anybody else needs added, send me an email. I'll get you added. And this will be sent out. It will also be up on our Facebook page, which you can find us at United Spinal NEO, as in Northeast Ohio. Facebook is always one of the first places I put announcements and other research opportunities and any other events. Adapted Sports Program of Ohio is doing a couple of sled hockey games. So if hockey is a sport and you want to try it, there's a couple of dates that are up on our Facebook page, as well as it was in the email. So lots of things going on. If you're interested, thank you so much for coming. Our next meeting will be November 16th. November 16th. And we will have the PAM Specialty Hospital of Denver talking about pressure sores and how to prevent them, and hopefully how to heal them. So stay tuned for all of that information. Hope you can join us. That'll be our last meeting of the year. We usually don't have any in December, as it's right around the holidays and a busy time for everybody. So yeah, hope to see everybody next month. If you need anything from any of us, you can always send the chapter an email at unitedspinalneo@gmail.com. One of us on the board will check it and get back to you. Yeah, so if you need anything, let us know. Otherwise, have a great month. Hopefully we can connect some other time. So thank you, everyone. Have a great night. Bye.
Thank you very much.
Great meeting. Thanks for inviting me.
Thanks for coming, Julie.